Good afternoon. Now we are starting this session. The first lecture that is on the diagnostic method of drug and allergy. I invite Dr. Siteshroy. In this session, we have a galaxy of speakers. They are all stalwarts. And first speaker is Siteshroy. To introduce him, he is MBBS, MCPS, MD USA, FAAP, FAAAAI, FAAAAI. He is super specialist in immunology and allergy and asthma. He is founder director of drroy Health Solution Multispecialty Clinic, Bandra, Mumbai. So I invite you, sir, Dr. Siteshroy.
Thank you very much. First to the organizers, to Dr. Kiratkar for being the first person to connect with me and inviting me to this podium. It's a great pleasure to be here amongst you all. And without further ado, I will start this program on the diagnostic methods in drug allergies. Clearly, this is a topic that all of us are faced with. It is a very complex topic. Literally, we conduct in the US a full-day workshop on this topic. So I'm trying to combine or compress some of the key concepts of that into the next 25 minutes. And I hope that the end of it, you all will have a bit more clarity on how to approach these cases. So we'll begin by what we call the definitions. When we think of an adverse drug reaction, we talk about all the unintended pharmacological effects of a drug. These can be IgE mediated and they can be predictable or unpredictable. There can be idiosyncratic reactions, which is something we always have to remember with drug allergies. And ultimately, there can be something called a drug intolerance. And the classic example of this happens to be with non-steroidal anti-inflammatory drugs, which often we get referred because people think they have an IgE-mediated reaction to the drug, when in reality, it's not an IgE-mediated reaction. It is more of a chemical pathway and an enzymatic issue that causes these reactions. It's important at the very outset to know the difference between these, because when you get these cases referred to you from a very careful history that we shall see what the main points are, it becomes extremely important to decide on what your line of approach will be for that case. When we talk about a drug hypersensitivity, this can include a variety of different mechanisms, but largely all immune-based. When we talk of pseudo-allergic reactions, we are talking of a classic example of radio contrast media, where a high osmolality weight radio contrast drug can give a reaction, but a low one will not. And it's largely due to a direct mast cell degranulation and histamine release. And no matter what testing you would do on a skin test or an intradermal test or a patch test, nothing would come up because there is no immune mechanism there. We know about anaphylactic reactions very well, and then ultimately we'll later on talk about desensitization. The WHO definition is a very wide definition for an adverse drug reaction. It obviously includes everything allergic, non-allergic, immune, non-immune, to say that it's any noxious and unintended reaction that occurs at doses that are routinely and commonly used for a variety of different purposes officially. Side effects from a drug are different than an allergic reaction or an adverse drug reaction. Overdoses are different, and so are secondary effects of a drug, which you classically look at a Herxheimer reaction when you give penicillin in syphilis. Looking at the epidemiology, we have to turn to US data because data from India is very limited, and I've presented a little bit of it here. But the estimated prevalence is about 4 per 100 admissions, and the cost if someone gets a reaction in the US is about $7,000 US. In India, whatever data we have available, 2 to 3% is the risk. And if a reaction occurs, the cost or the cost incurred can range from 1,000 rupees to changing the drug, identifying and getting a consultation, to actually getting hospitalized and treated can be close to 1 lakh rupees. These reactions in the US cause about 75,000 to 106,000 deaths every year. That's a very high number. 51% of all serious adverse reactions are actually reported to the FDA, and fatal drug reactions occur in about 0.32%. Outpatient drug reactions, which are very rarely reported, make up to 35% of cases when you combine the age groups that you're looking at. Allergic reactions actually amongst the adverse drug reactions make up only 25%, maybe even less if you do very careful studies. Penicillin, amoxicillin, Bactrim, these have always been thought to be the commonest drugs that cause reactions, but the list has grown, as been mentioned, with anticonvulsant drugs, a lot of other combinations, and any organ can be affected in the body. In hospitalized patients, we are looking at 15% getting some sort of a drug reaction. Is the fourth leading cause of death in hospitalized patients. Imagine that's a very high ranking for a drug reaction. In India, they are never reported or hardly ever reported or confused with other reactions or causes in multiple morbidity patients, and hence we don't have data. There are almost 2 billion cases of serious drug reactions in the US every year. Drug reactions are common. Drug challenges, we shall come to this a little bit later, but these are done in a variety of different ways, what are called graded dose reactions or test dose reactions. These are indicated in patients who have a low risk. And it's only after completing this kind of a challenge can we do further planning in terms of administering that drug or alternative drugs to the patient. This data I have already presented. When we look at the classification of adverse drug reactions, again, important to recognize there is what is called type A reactions, which are common, predictable, and dose dependent. A classic example would be getting tremors after albuterol. We've certainly had patients who've thought they're having an albuterol allergy because they got tachycardia and tremors. We can also have drug interactions, which can be in this class and well known, well described. And then there are the type B, which are uncommon and unpredictable. And within this, you would have all the classes, including the IgE and non-IgE mediated reactions. And in this, again, even the pseudo-allergic reactions like the red man syndrome with vancomycin come in. The classification of hypersensitivity reaction, remember, this is one subsection of the type B reactions, which are unintended, unpredictable, happens to be the drug hypersensitivity reactions. And in that, we have the type 1 IgE mediated reactions, the classic anaphylactic or allergic reactions, the type 2 antibody mediated reactions, which is exampled by the hemolytic anemias that may come up during penicillin administration, the type 3, which are the immune complex mechanisms like the amoxicillin induced serum sickness. I'm taking the same drug and showing that there are different mechanisms by which it can cause a problem. And lastly, the type 4, which is the classic amoxicillin-induced maculopapular rashes that might be present. So recognizing that the same molecule, the same drug presenting in multiple different ways causing a reaction is what complicates the entire evaluation process of drug allergies. Because in this situation, you need to know a lot of different factors. One of them is what are the risk factors. So the risk factors can range from drug factors, such as the chemical property of the drug, the molecular weight of the drug, the dose, route, and administration of the drug, where we know that intravenous reactions happen to be more serious or more likely to be causing a major issue than the oral reactions, which are fewer and easier to manage. We also recognize that the intercurrent illnesses, the other drug exposures all create a problem. When we look at HIV, the reaction to typical Bactrim, trimethoprim sulfa, which can be very high, where it's the disease and the drug, the combination causing a problem. Similarly, we know a lot of Epstein-Barr virus infections where if amoxicillin is given, a rash will develop. And again, this can be as high as 30 to 100% of the cases that are administered. So in these situations, these are all hypersensitivity reactions, but may not be reproducible in every situation because they are dependent on the individual circumstances of the patient. Then there are host factors. There's age, there's gender. Generally, drug allergies seem to be more common in females than in males. And then the underlying atopy. But atopy itself is not necessarily a risk factor for drugs. The genetics of the drug allergy are also very important, so much so that in certain parts of the world, like in Japan and certain other places, If you do not do a HLA phenotyping before giving carbamazepine and somebody develops a Steven-Johnson reaction, it's considered to be a major malpractice. Now, recognizing how widely we use these drugs and how commonly we do not have the DNA, the HLA phenotyping done, we can only imagine the kind of reactions that we may face. Similarly, for abacavir, which is a classic HIV drug, similarly, HLA-DR3 association with insulin gold and penicillamine. These are ways in which we could potentially narrow down the chances of a person getting the reaction, but obviously it adds cost, and the biggest issue is availability in terms of these tests. So when we come to evaluating or diagnosing a drug allergic patient, it's history, 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 followed by diagnostic tests, followed by challenges. What are we looking at? We're looking at the exact drug. We're looking at the dose. We're looking at the route. We're looking at the rate, time since the reaction, because there have been people who've had a penicillin allergy, or they think a penicillin allergy because a family member told them. I've had people who've confidently told them they had a Bactrim or a sulfa allergy. And when I asked them, they said, because my mother had it and she told me I should never have it. So it becomes very, very important to really get into the details and not just take a drug allergy history at face value. The dose or the days into the course, the co-administration of the drugs, the coincident infections, as I mentioned earlier, the symptoms, examination, lab findings. Sometimes patient will take photographs, which are immensely beneficial. And if I get a call ever for these, I immediately ask the patient to take pictures. Even if I don't have the initial onset, even in the mid or the latter part, it can be very beneficial to make a diagnosis. And then in terms of the treatment, what was required for the patient to get better, because according to the patient, getting a rash all over the body is a severe reaction. We know that a severe reaction is not just a rash over the body. We are looking for more anaphylactic or other systemic symptoms before we call it severe. The name of the drug, this is the biggest challenge that I face in my practice, because people will come to me and they don't know what drug they reacted to. And we sometimes have to go to great length to call their primary care physician, their treating physician, get their hospital records, try to identify what was given, because we may be looking at what people think or they think they have because someone told it, and the real data may be completely different. When the reaction occurred, how soon after consumption or getting exposed to the drug matters greatly. If it is less than 6 hours, we're looking at immediate hypersensitivity. If it is more than 6 hours, we're looking at potentially delayed hypersensitivity, except in the case of oncology drugs, where after the pre-treatment that has been given for the oncology drug, the reaction could come up after 6, 8, or 12 hours. So was the medicine prescribed? Why was it prescribed? Very often, if it's a respiratory infection and it's a post-viral exanthem that is coming up, it may be blamed on the drug that was used during the viral infection. So were there any other medications that were being taken? Was there any previous exposure to the drug? And sometimes was there any post-exposure? So patient may have had 3 or 4 reactions. They come to you, they have the history, we identify it. We recognize that since the reaction, they have had the same drug with different brand names and never had a reaction. You don't need to do any testing in such cases. And then do you have the same symptoms without taking the drug? I've had plenty of chronic urticaria cases that have come to me thinking they have drug allergies, and what they actually had was idiopathic chronic urticaria. Obtaining an accurate history, performing a physical examination if you're seeing them during a reaction, identifying all the potential drugs. Some you may be able to eliminate, some not. Have an open mind about the mechanism involved, and then check for the underlying diseases with it. The chemical property, the previous history, which increases the risk by up to 5 times, a previous reaction, age when it occurred. As I said, women are at greater risk, route of delivery, dose, and genetic factors. We'll focus now a little bit on type 1 IgE-mediated reactions, which is our biggest concern because they lead to anaphylaxis. Usually begin within 2 hours of exposure, can be, as I said, up to 3 or 4 hours also, can recur or worsen with repeated exposure. Skin testing may be helpful. If convincing history and skin test positive, then these patients may require desensitization in the future. Classic symptoms of anaphylaxis, I don't need to go over with you because you have already heard this plenty of times and will in the next day that remains. Cutaneous, mucosal, gastrointestinal, respiratory, cardiovascular, neurologic. Remember, you need only 2 systems to be involved to be called anaphylaxis. Diagnostic tests. This is the crux and the summary of the entire presentation. Okay. This is all we have when it comes to diagnosing drug allergies. The first is a skin prick test, has to be done very carefully and very accurately. Then comes an intradermal skin test, which helps us with the delayed reactions. Then come the in vitro IgE, specific IgE tests, which are very limited, available for things like penicillin, amoxicillin, and insulin, heparin, very few drugs. Patch testing, which we rarely resort to, but is an immensely beneficial test that I use in my practice very routinely along with the intradermal testing. Then come the drug provocation test, which will include the graded dose challenges, which can be single dose or multi-dose, never more than 4 doses if you're doing a dose challenge. Lymphocyte transformation test, an experimental process, basophil activation test, an experimental process, and HLA genotyping, which is very clearly proven for a bunch of different drugs. These are some of the manifestation of the IgE exam findings. Okay. We know that there can be flushing on the palms, there can be angioedema that can come up, there can be urticaria and hives, there can be erythematous pruritic lesions, which may not always look like classic urticaria, but behave like it. When we are doing the skin testing, we are assuming that there is an IgE-mediated reaction that is there. All patients with an unknown reaction may be considered for IgE mechanism. Remember, this is a very important test. There is no role for skin testing a patient with Steven-Johnson or toxic epidermal necrolysis or the drug-induced eosinophilia syndromes that are there, the acute interstitial nephritis, the exfoliated dermatitis, or the hemolytic anemia, because these are classically non-IgE mediated reactions. You have to avoid antihistamines for at least 3 to 5 days, ideally before the test. You want to hold beta blockers a day before, because if someone gets anaphylaxis, you don't want to be, or you want to use the very cardioselective beta blockers. And you can get results within 15 to 20 minutes if it's a drug that's clearly involved. There's epicutaneous or the prick testing, and then there's intradermal testing. This is a very important statement that I've put here, okay, which everyone needs to hear listening to this lecture. Actually validated, confirmed, proven, accepted worldwide. Allergy skin testing is only available for penicillin, for no other drug. Everything else that you do, you're doing on the basis of a potential that you may pick up an IgE-mediated reaction, but there are a lot of unknowns about it. You have to know what is called the non-irritating concentration. I get a lot of cases referred to me where someone has done a test, but the test has been done with such a high concentration that you get a non-specific mast cell degranulation and a wheal and flare response, and the patient comes to us thinking that they are highly allergic. It's fast, it's useful, it's sensitive, it's reliable when it comes to penicillin. And with penicillin skin testing, if it's positive, it has a 60% positive predictive value. If it's negative, it has a greater than 90%, 97 to 99% positive predictive value. But how is that test done? That's very important. Remember that most drug allergic reactions, drug reactions are not allergic in nature. There are other tests that are available, but remember that something called the IgG testing, and there are several labs in India that do IgE testing for a bunch of different drugs. Okay, there are panels from Gujarat, from Jalandhar, which claim to do up to 25 or 30 drugs on their blood test. And those are not accurate tests. The approved ones for specific IgE are only 6 drugs in the world. Serum tryptase can be useful. I have actually not shown here for, I'll come to it later for the penicillin testing, what the algorithm is, because while I say a penicillin drug testing is approved worldwide, the mechanism is very different. These algorithms, I shall not get into great detail in the interest of time, but right from when a patient develops an adverse drug reaction to reviewing everything I said, to actually figuring out from your experience and reading whether you suspect an immunologic or a non-immunologic mechanism. If you're suspecting a non-immunologic mechanism, then you can just modify the dose, the drug, find an alternative, and not have to do anything else really in those cases. And if you believe that there is a drug, then you will have to perform a confirmatory test, as I mentioned, one of these. If it has a high negative predictive value, then the patient is clearly not allergic to it, like would be in a true penicillin testing. And the patient may still have an allergy if it doesn't have a very high negative predictive value. When we look at the algorithm, we are again looking at identifying what would be anaphylactic so we can give them the right prevention mechanisms, including adrenaline and the entire shebang with it. Avoiding the drug where possible, that's always the top priority. And only if I get a written communication from a doctor saying that this is the only drug that will work in this situation, will I ever even consider doing a drug desensitization. Considering prophylactic regimens before you give the drugs, depending the mechanism, future prudent use of that class of drugs, and also patient education. I'm going to spend a little bit of time on beta-lactam sensitivity because this will give you all an idea of how tricky the entire field of drug allergy and drug allergy diagnosis is. Penicillin, we know, is one of the commonest causes of anaphylaxis and deaths worldwide, even today, okay, despite all we know. The parenteral route is the riskiest, and I have patients who have parenteral allergy who can take the oral drug without a problem. The skin test will determine a true risk for reactions and can potentially avoid expensive alternative antibiotics and also drug resistance in the future. The prevalence can be as high as 10% of patients admitted to the hospital. History alone is not reliable. 80% of patients who think that they have a penicillin allergy actually don't have an allergy when they are carefully tested. And 20% of patients with a documented history will have a test. We realized that penicillin antibodies can wane over time. 15 to 20 years is the timeline over which we have seen these allergies actually go away because of non-exposure. Can there be resensitization? Absolutely can be, but it is not a very common thing. And again, if patients are mislabeled as being penicillin allergic, then quinolones, vancomycins, much higher classes of drugs might be used and drug resistance might increase. This is a very important slide for anyone who wants to understand the complexity of penicillin allergy testing and the way we do it in India. There is a commercially available, what we call penicilloyl moiety of penicillin, which is called pre-pen commercially, which is always in shortage even in America, and we absolutely don't have it available here in India. And I have tried very hard to try to get it here, but in terms of availability and routes, it is not a common thing that we can get. The remaining agents, which are called the minor determinants, penicilloate and penicilloate, which are antigenic determinants, can be tested through testing for PENG, which is what we have it in the intravenous form. The minor determinants have to be made fresh every time you're going to test for it. And it's most reliable when you have tested with the pre-pen and with the minor determinants that you can say with 99% certainty that a person doesn't have a reaction. Now, what do? We do only with PENG because that's all we have available. If you do only with PENG, you can actually miss up to 20% of anaphylactic reactions. And which is why I tell people that a negative allergy test to a drug is not equal to the person taking the drug safely. You still require a graded dose challenge or potentially a desensitization protocol, depending on how severe the original reaction was to the drug. And this is where an allergist consultation becomes very, very important. As I said, 20% of patients can have a history of anaphylaxis and react only to the minor determinants. Benzyl penicillin is what we commercially use. It is diluted usually to a 1 to 10,000 units per ml dose. The mixture of minor determinants not commercially available, that's PENG, is stable for about 1 week after it is prepared. And the first do the prick skin test with the pre-pen and the PENG with positive and negative controls, so your saline or buffer saline and histamine, and only then proceed further. You then, once you have done that and it's negative, then you will have to do the intradermal testing starting from a 1 to 1,000, 1 to 100, 1 to 10, and in the end, a full strength concentration. And as I said, the positive predictive value still at best is around 60, can go up to 100%, and the negative predictive value is almost 100%. If the skin test is positive and there is no history of immediate reaction, do not use penicillin or its derivatives. If you can use an alternative non-cross-reacting drug, typically the second generation cephalosporins or the third generation cephalosporins hardly cross-react with the penicillin group. And penicillin skin testing does not cause sensitization. That is a concern that people have. When you want to delabel a patient who's been labeled as penicillin allergic, when you compare skin prick test to direct challenge in patients with a weak history, the direct challenge always comes up better. Patients with a vague history, more than 10 years or within 1 to 10 years. Patients with no acute allergic reactions, in these, it's easiest to do an oral challenge with an amoxicillin or a derivative similar to it. And you can very often delabel that patient as being penicillin allergic. When the skin test is negative and the history is weak, you are then administering the drug with a super cautious approach of giving 1/10 of the dose. In some cases, I've gone even lower. If you are doing it for a desensitization protocol, then you are actually giving it with an ICU backup or in the ICU with the approval of the other treating physicians that this drug is absolutely essential for the treatment of the patient. If you do not have that, medico-legally, it's a huge issue, because the question will come up, God forbid if something goes wrong, why did you not use the alternative when it was available? Okay. Oral desensitization is always an option. It's a little easier, less risky, but IV is required in certain situations. Cephalosporin allergies, 11.4% of all antibiotics used can cause hypersensitivity reactions. Prevalence is about 1.3%. Inpatient, 4 to 6%. Women more than men. And cephalexin. So the first generations are common. Cefazolin has been associated with anaphylaxis, cefaclor. So any drug, I was just having a conversation with one of my colleagues and I told them that even after knowing a lot about drug allergies, if I get a case, I go back and review the literature to see what is latest, what is new, and to figure out what is the most approved protocol most currently for that drug to be tested. Without it, you're actually missing out, because this is a highly dynamic field where it is being studied. A graded drug challenge by an allergist is needed to confirm or disapprove the diagnosis ultimately, even with a cephalosporin negative testing, skin and intradermal, which has been done. As a point, when you have patients who have maculopapular rashes, which is the delayed reactions which come after a day, 2, 5, sometimes a week, in these situations, it becomes very important to do the intradermal delayed test and also to do the patch test before you can. I shall skip over some of the other points and just come to the last part of my talk. I'm not going to go through this desensitizing because the focus is on diagnosis. When do you refer a cases of drug allergy? When you have a case that is a clear penicillin allergy, unclear drug history, more than 2 medications that you're concerned about, an aspirin or similar kind of drug, a lidocaine allergy, which is not at all common, chemotherapic agents, these are very classic referrals that we get. So in short, hypersensitivity reactions are a small subset of adverse drug reactions. If allergy is suspected, you have to do a careful history, a very good physical examination, or look at pictures from there, distinguish between a mild, moderate, or a severe reaction, and then proceed with the skin testing, prick or intradermal or patch, followed by challenge test dosing, and if necessary, drug desensitization whenever it's necessary. So with that, I shall end my talk. Thank you very much for the time and appreciate it again to the PDallerCon organizers and the team here and the central IAP teams for having me here. Thank you very much.
Thank you, drsiteshroy. You are very important things. That history is very, very, very important in the drug allergy. Thank you once again.